Hello everyone. Our lecture is about breast pathology. We will discuss the most important diseases that occur in the breast tissue. Topics to be covered are: number 1, introduction; number 2, clinical presentation of a breast disease; number 3, inflammatory process; number 4, stromal neoplasm, which include fibroadenoma and phylloid tumor; number 5, benign epithelial lesions; and lastly, most important subject in our lecture, which is breast carcinoma. The most important feature that distinguishes the breast from other organs: first, rather than being essential for survival, the major function is a nutritional support for another individual, which is the infant. The second is the structure of organ undergo marked changes throughout life, such as expansion of the lobular system after menarche, periodic remodeling during adulthood, and involution and regression of the lobule. Finally, the breasts are visible and as a result social, cultural, personal significant, but not shared by other organs. So, all these features that play an important role considering the origin and presentation and the treatment of a breast disease. The functional unit of a breast is the lobule, which is supported by a specialized intralobular stroma. The origin of a breast disorder, as you look in this picture, that originate either from luminal cell or myoepithelial cell or intralobular stroma and other from interlobular stroma. Clinical presentation of a breast disease. Most symptomatic breast lesions are benign. Of women with cancer, about 45% have symptoms, whereas the remainder come to attention throughout screen test. Mastalgia, it means the pain in the breast, which is most common symptom of a breast disease that often related to menses, possibly due to cyclic edema and swelling. When pain is localized in a specific area, it is usually caused by ruptured cyst or a trauma to adipose tissue, which means fat necrosis. Almost all painful masses are benign, but of unknown reason, a small fraction of cancer, about 10%, cause pain. The second clinical feature is inflammation. Inflammation causes an edematous and erythematous breast, which is rare occur, and when occur, it is most often caused by infection. Third is nipple discharge. Nipple discharge may be normal when small in quantity and bilateral. The most common benign lesion producing a nipple discharge is papilloma that arising in the large duct below the nipple. Discharges that are spontaneous and unilateral and bloody are of great concern for malignancy. Lumpiness or diffuse nodularity throughout the breast is usually as a result of normal glandular tissue, but when pronounced, imaging study may help to determine whether a discrete mass is present. Gynecomastia is the only common breast symptom in the male. There is increase in breast trauma and epithelial cells, resulting from imbalance between estrogen and androgen. This is a nice figure that shows presenting symptom of a breast disease, as in the A, a common breast-related symptom that bring the patient to clinical attention in general, while in the B, the presentation of a breast cancer. An inflammatory process. The inflammatory diseases of a breast are rare and may be caused by infection, autoimmune disease, or foreign body type reactions. The symptoms, which include erythema, edema, and often accompanied by pain. Because the inflammatory diseases are rare, the possibility of the symptoms are caused by inflammatory carcinoma should always be considered. The most important inflammatory process of the breast is the breast abscess. The only infectious agent that causes breast disease with any frequency is Staphylococcus aureus. The lactational abscess, collection of the neutrophil and associated bacteria in the fibroadipose tissue. If untreated, the tissue necrosis may lead to appearance of the fistula tract opening onto the skin. Stromal neoplasm of the breast. The two types of stroma in the breast, intralobular and interlobular, give rise to different types of neoplasm, which are fibroadenoma and more cellular, which are phylloid tumor. This is a gross picture of the fibroadenoma. As you look, that there is well circumscribed, lobulated contour, white-gray color, lobulation balls above the gut surface, slit-like space. This is microscopical picture of the intralobular stromal neoplasm. In the A, there is fibroadenoma. The benign tumor has expansile growth pattern with pushing circumscribed border and low cellularity, while in the B, the phylloid tumor has proliferating stromal cells distort the glandular tissue, forming a cleft-like space and bulge onto the surrounding stroma. Benign epithelial lesions. Benign epithelial lesions that include non-proliferative disease, which is not associated with an increased risk of breast cancer. The second is a proliferative disease without atypia that has slightly increased in the risk of a breast cancer. And the last, which is the most important one, which is a proliferative disease with atypia, which is important. Why? Because which is precancerous, that associated modest increase in the risk of breast cancer. Non-proliferative disease of breast, which is microscopically has cyst, fibrosis, and adenosis, because the lesion contains single layer of epithelial cells. So it is non-proliferative. The most common non-proliferative breast lesions are simple cysts lined by layer of luminal cells that often undergo apocrine metaplasia. When cyst is ruptured, chronic inflammation and fibrosis in response to swelled breast may produce palpable nodularity of the breast, so-called fibrocystic changes. Proliferative disease without atypia, which include epithelial hyperplasia, sclerosing adenosis, complex sclerosing lesion, and lastly, which is papilloma. Proliferative disease with atypia, which include atypical lobular hyperplasia and atypical ductal hyperplasia. This is microscopical picture of benign epithelial breast disease. In the A, non-proliferative disease, an apocrine cyst is shown that is a common feature of non-proliferative breast disease. In the picture B, proliferative breast disease, which is characterized by increased numbers of epithelial cells, as in this example, epithelial hyperplasia. In the picture C, the proliferative breast disease with atypia, the proliferative epithelial cells are monomorphic in appearance and built up to form abnormal architecture structures. Breast carcinoma. Breast carcinoma is the most common malignancy of women globally, and the lifetime risk of a breast cancer is 1 in 8 for women living to age 90 in the United States. Epidemiology and risk factors of a breast carcinoma: age, gender, breast density, estrogen exposure, epithelial hyperplasia, menstrual reproductive history, family history, and genetic predisposition. And also other risk factors, which include radiation exposure, breastfeeding, exercise, obesity, diet, carcinoma in the contralateral breast, and lastly, which is tobacco. Pathogenesis of breast cancer. This is most important subject in the breast cancer. The pathogenesis of breast cancer is multifactorial. That includes 3 factors. First of them, genetic, and second is hormonal influence. Third is environmental factor. The genetic factor as the driver mutations in the cancer genes that contribute to breast carcinogenesis can be divided into those that are inherited and the second, those that are acquired. The most important gene that is responsible for pathogenesis of breast cancer, which are BRCA1 and BRCA2 gene. Both of them encode proteins that are required for repair of certain kinds of DNA damage. The second other gene, which are TB53. The second factor is hormonal influence. Estrogen stimulates production of growth factors such as transformation growth factor, alpha platelet derived growth factor, fibroblast growth factors, and other, which may promote tumor development through paracrine and autocrine mechanism. The third is environmental factor. Environmental influence are suggested by variable incidence of breast cancer in genetically homogeneous group. Genetically homogeneous group, for example, Japan's women living in Japan and United States. Classification of breast cancer. Many classifications of the breast cancer, some of which depend on morphological type and other on molecular type. In this diagram, we show the classification of breast cancer that depend on morphological type. Breast cancer either in situ carcinoma or invasive carcinoma. In the in situ carcinoma, either it is ductal or lobular, while in invasive carcinoma, many morphological type. The most important them is infiltrating ductal, and other, which is lobular or tubular or mucinous or medullary and other type. Also on morphology, we note that the grade of the carcinoma depends on the nuclear pleomorphism, glandular tubule formation, and mitotic rate. So we classify as grade 1, grade 2, grade 3. Grade 1 when it is well differentiated, grade 2 when it is moderate differentiated, and grade 3 when it is poorly differentiated. This is important classification that depends on morphology of the breast cancer. Molecular classification. Classification system relies on gene expression profiling. This system, which is currently used, mainly in context of a clinical research. Divide breast cancer into 4 major types, which are: number 1, luminal A. The majority are low grade, which are ER positive cancer and HER2 negative. The second, which is luminal B. The majority are higher grade and ER positive cancer that may be HER2 positive. The third type is HER2 enriched. The majority overexpress HER2 and do not express ER. Fourth and finally, which is basal-like, the majority by gene expression are ER negative and HER2 negative. Morphology of a breast cancer. The most common location of tumors within the breast is the upper outer quadrant, about 50%, followed by the central portion, about 20%. About 4% of women with breast cancer have bilateral primary tumors. Breast carcinoma either as A. non-invasive or B. invasive. In the A. non-invasive, which are either number 1, ductal carcinoma in situ, or number 2, lobular carcinoma in situ. This slide shows the carcinoma in situ of the breast. In the A, which is lobular carcinoma in situ, while in the B, ductal carcinoma in situ. Paget disease of the nipple. Paget disease of the nipple is caused by the extension of ductal carcinoma in situ up the lactiferous ducts and into the contiguous skin of the nipple, producing a unilateral crusting exudate over the nipple and areolar skin, as in this picture. This is a microscopical picture of Paget disease of the nipple. Show malignant cell with large pleomorphic and pale cell that invade the epidermis of the skin of the nipple. B. Invasive infiltrating carcinoma of the breast. The microscopical appearance varies from tumor with well-developed tubules and low-grade nuclei to tumors consisting of sheets of anaplastic cells. The majority of invasive carcinoma, about 70% of a breast cancer, which is invasive ductal carcinoma. The invasive ductal carcinoma produces desmoblastic response, which replaces the normal breast fat, resulting from mammography density and eventually lead to appearance of hard palpable irregular mass. This is microscopical picture of invasive ductal carcinoma. Second is invasive lobular carcinoma. In this slide, microscopical picture of invasive lobular carcinoma show infiltrating cells that are morphologically similar to the tumor cells seen in lobular carcinoma in situ. The cells are invade the stroma individually. Third type of breast cancer as morphological type, which is carcinoma with medullary features. Carcinomas with medullary features typically grow as rounded mass that can be difficult to distinguish from benign tumor on imaging. This slide shows microscopical picture of carcinoma with medullary features, which consist of sheets of large anaplastic cells associated with pronounced lymphocytic infiltration, mostly T lymphocytes. Fourth, mucinous colloid carcinoma. Mucinous colloid carcinoma usually usually soft and gelatinous because of the presence of mucin poles that create an expansile circumscribed mass. This slide shows a microscopical picture of a mucinous carcinoma. The tumor produces abundant amount of extracellular mucin. Tubular carcinoma. Tubular carcinoma is almost always detected on mammography as a small irregular mass. The tumor cells, as in this picture, are arranged in well-formed tubule and have low-grade nuclei. In the tubular carcinoma, the lymph node metastases are rare and the prognosis generally excellent. Inflammatory carcinoma. Inflammatory carcinoma is defined by its clinical representation rather than a specific morphology. This is a typical picture of the patient presented with inflammatory carcinoma, which is present as swollen erythematous breast without palpable mass. This is a microscopical picture of inflammatory carcinoma of the breast. There is obstruction of dermal lymphatic space and diffuse infiltration that cause the inflamed appearance. True inflammation is absent. Prognosis of breast cancer. The clinical outcome for a woman with breast cancer can be predicted based on the molecular and morphological features of the cancer and its stage at the time of diagnosis. Factors that influence outcome include the following. First of them is biological type. Second is proliferation, which is mean mitotic count. Third is expression of estrogen or progesterone receptor, which predict to response to anti-estrogen therapy. Fourth is overexpression of HER2, which is seen in about 20% of breast cancer. 5 is RNA expression profile, is a newer method of subclassifying breast cancer. And lastly, which is important one, which is tumor stage. Stage of a breast cancer. Tumor stage is measure of extent of a tumor at the time of diagnosis, and it is important for all biological types of carcinoma. It is based on number 1, primary tumor, number 2, regional lymph node, number 3, presence or absence of distant metastasis. So the stage of the breast cancer, which is T and M. T, tumor size, N, lymph node, M, distance metastasis.